Welcome to another episode of Cutting Edge Health. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand their options for knowing how to be able to deal with pain, whether it's physical or emotional, and knowing those options so you're empowered to make good choices. Today, we're talking about Grey's Anatomy and why it has gotten it wrong. Frequently, they talk about open back surgery. With one episode, I want to say from season 9, the aspect of the show has been on since May of 2005, and now it's in its 20th season. And you would think that they'd have some things right. So they have this episode where you have these various different doctors that are doing open back surgery after they've evaluated and looked at the spine. And in this particular episode, they decide, after much, turmoil and discussion, hey, we've got to be able to do back surgery that's open and it's going to make the patient better. So, as you could probably guess, this isn't always right. What we think of many times is, particularly if someone has pain as the motivation for back surgery, that they get an injection, they get medications, we see how they do. We maybe do some physical therapy, conservative bracing, and things along those lines, which typically don't work. And so then we're saying, surgery is the solution. If you hadn't guessed, it's wrong. So there are different options that are present for being able to treat this rather than just open surgery alone. So what are some of the options? That's what we're going to talk about today, so that you're empowered and you have basically options to say, what else could I do? So we want to provide you with 3 different treatment options that when you walk away from this talk, you understand that. So the first option that we talked about before in other videos are things like Vertiflex, where you have a treatment that is on the right-hand side, this purple kind of umbrella / stenting type device that basically spreads the spinous processes. It opens up the area so that compressed nerve roots aren't squeezed down quite as much as what they were before. And it also helps that canal. How well does it work? Well, these are the numbers. That for those patients over 5 years, not just over 2 to 3 months that you sometimes see with an injection, and sometimes longer than what you see from traditional open surgery infusion, there's 66% improvement in back pain, 75% improvement in leg pain, 85% reduction in painkillers and opioids, and 90% satisfaction, which is better than most treatments. The fact of the matter is that type of procedure is something that's done under anesthesia that's called MAC anesthesia, not even traditional general, and can be done in probably under an hour with a return to home the same day. Another type of treatment that we've talked about on this channel with some degree of frequency is the mild procedure that I mentioned previously. And so that's a procedure where you have the squeeze and stenosis that's present. And in essence, what you do is you use certain types of tools to come in here and you clean out this area so that you don't have the squeeze that's preventing you from being able to walk and being able to do the things that you want to do. What most patients will ask me is, well, I haven't heard of it before. I know, because typically, we're not talking about options. We're talking about giving you just traditional solutions that are injections, or us talking about traditional surgery, and you don't necessarily need it, right? So how can we be able to give you some other insight? Well, how well does that work? It works this well. So it improves the ability to be able to stand by 600%. Increases standing time by 7 times, and it's able to improve walking distance by 1,500%, which is unheard of. It increases the walking distance by 16 times. And so what most patients would ask me is, well, yeah, I haven't heard of it. Is it safe? And both of these 2 options are safer than traditional surgery. And that's across all boards, whether you're talking about traditional laminectomy and fusion, whether you're talking about the aspect of microdiscectomy, and we're going to talk about what that really means. Today, we're going to talk about a bit of disc herniation and how to be able to treat this without you needing open surgery. So when we look at this, about 70% of the population to 85% of the population has low back pain, and traditionally is secondary to lumbar disc herniation, which is what LDH is. And it results sometimes in motor dysfunction with nerve compression. So if we look at this from the broader sense, most of the time, those discs resolve and they don't continue with compression, causing these symptoms. However, there are times where the disc does not. And then we have this sort of discussion that takes place about, no, we got to do something. We have to intervene with traditional surgery. That's the treatment choice. But is it though? So when we compare it and we look at the studies and we look at something that's called the SPORT trial that looked at traditional surgery, and we look at it and we compare to traditional endoscopic discectomy, which is what we're going to talk about today, one of the things that we can be able to see and determine is that the blue is the traditional surgery, the green is endoscopic. And what we're talking about is the percentage of bad things that happen. The higher the bar, the worse it is. And what you can see is that it's worse with reherniation, it's worse with dural tears, it's worse with an infection. So what do these different things mean? Traditional open surgery has more infections that occur. It has more times where you get into the area where the CSF fluid is and you have leaks. You have more likelihood of having recurrent herniation, meaning that this bulge comes back and has a problem again. And you can see the overall complication rate is almost twice as high as what you have by doing it a different way. So let's explain to you the different way so you have some semblance of saying, I get what this is all about. So when we look at the spine, and particularly when we look at the spine just from front to back, we have a picture sometimes like this. What we can see is there's vertebral bodies that are in place, and we can see different parts of the vertebral bodies. In between the vertebral bodies, we can see these discs that act as spacers that give us a degree of buoyancy and give the spine the ability to be able to be malleable to the extent that it can be able to turn and twist different than otherwise. So this is the lower area of the lumbar spine. We can see different demarcations of things like the pedicles and lamina. And in essence, what we're hoping to be able to kind of gain from this is that we have these kind of square blocks that then the discs sit upon, and exiting in this area are the nerve roots. And sometimes the discs get in the way of the nerve roots. So a cartoon picture that kind of explains this differently shows the following. We can see is those same little circles where were supposedly the pedicles in the other actual anatomical picture, that they have this curved line that comes out. And this curved line is the nerve root. Historically, what we've been taught is the bottom picture where you would place a needle in and around the area to say, okay, this is the safe place, the traditional placement. Well, there's something that's called a Keyman's triangle, which is an area that we can be able to get into that area in that region with either a needle or a tool. And in some ways, it's safer, it's bigger, and it's easier to be able to access. So when we highlight this by giving that same type of picture, an injection that shows the nerve root, you can see this area in this region. And to try to slip in underneath can be incredibly challenging without touching the nerve, but trying to come in from below is a much more simpler. And we're going to use this concept to be able to explain this treatment option that's in place. So when we think about disc herniation, there's a whole host of different ways to kind of conceptualize this. But a pictorial representation is the following. On the left, you can see that area of a normal disc where if we're cutting away and we take a look, we can see the spinal cord that's in place. We can see kind of this TP or triangle on top, which is indicative of the bone with the spinous process and the lamina that's in place. And then what we can see is this disc that normally should be flat against the area of the spinal cord without a compression. On the right-hand side, we can see a herniated disc that has this compression with this redness now of this nerve root that's being squeezed. There's different types of compressions that we're going to talk about and where they come from. But at the end of the day, what we can be able to determine is that normally it results into a pressure on the nerve, which is one of the reasons why, as a clinic, we started focusing on nerves, the spinal cord, and the brain as a whole in terms of how we intervene and how we treat. In essence, interventional neurosciences. So what we look at from this is we can see that there's different areas. The blue in this demarcation is right as a central component of being squeezed. The red is something that's called the lateral recess. The green is something called the foraminal zone, which is where the nerve root exits out from. And the purple is this far lateral zone. All of these are indicative of where the nerve root can come from, and whether the disc can come from, rather, and how it can squeeze different structures in that area and cause problems and issues. Traditional surgery does something that's called a microdiscectomy. And to the layperson, it sounds minimal because it's micro, like a microscope, right? Well, it's not. So the way it actually works is the following, is that you have these tubes of ever increasing size that you place into the tissue after it's been cut in order to then be able to see the area of what you're looking for. So a picture would kind of look like this, where you make an incision directly into the muscle, and then you put a tube in, and then you look in with the aspect of the scope in order to be able to see what's going on, and therefore you can be able to kind of make a determination. So this is supposedly not as invasive as open, but in essence, it's the same thing as open. So if you were to take a look at that picture again, you kind of see a little bit of that same type of thing where you have sort of that element where you're looking straight down at it. Well, is there a better way? Well, actually, there's a couple different ways that are better than that. So one different look at this is to say, are there ways to be able to make this disc smaller without having to use that type of treatment? And yes, you can do things like laser, you can use an intradiscal treatment, you can use percutaneous, you can use an endoscopic approach, you can use various different injections into the disc, including ozone as well as biologics. All those things have value, but the fact of the matter is the approach can be even more valuable, which is what we're talking about today. So imagine instead of us coming straight down, they were able to get to the disc where it's actually bulging against the nerve root by coming into a straight line. Why would there be value to that? Well, using this next cartoon, we can be able to see this even better. So an endoscope is able to come into this area, and what you can't clearly see is it's going in between the areas where the muscles naturally divide. So this scope has muscles on the top portion of it and it has muscles on the bottom portion of it, but it's able to get into the area where the disc has a compression, which results in the ability to be able to have a much easier, not only surgery, but recovery period. So when we're able to be able to do this minimally invasive approach, it results in us having less infection, less reherniation, and less complications as a whole. So what does that look like in a series of pictures? It looks like the following. But first we take a picture and we can see this similar picture that we had before from the front, and then we can see a picture from the side. And what we see is the level that we're trying to be able to make a determination about. We can see the hole where the nerve exits out from. And as discussed before, what we're using is the approach that's a Cayman's triangle approach, where we can see this area and be able to place a trocar or instrument in that area. And then we use kind of these increasing size type of dilators that are in place, but it fits in between where the muscles are. And so why is that so important? Because what we've seen is when the muscles cut, it takes a much longer time to heal. And secondly, it doesn't always heal the way that we'd expect, which results in dysfunction. And sometimes that muscle doesn't stay muscle. It becomes fat atrophied, which then can worsen the degree of support for the spine. So what we want to be able to do is to get to the area, see what we need, and then be able to improve it accordingly. So what does that look like under scope? It looks like the following. What you can see is that you can see in these various different pictures, as that scope comes in, there's ways for us to clear that tissue out of the way and then be able to diagnose where the nerve root is and where the disc is in relation. So that way we can be able to take that compression and improve it, so that finally it would look something kind of this following nature, where you have a nerve root and you don't have a compression that's present. So at the end of the day, you're able to come into that area, be able to stop the squeeze, be able to do it safely where you don't have compression of the nerve root as you enter, and it results in overall improvement. So what does that look quantitatively? What it looks like is the following. We can see this where they looked at various different discs that were in place and what was the degree of result. And what they were able to find is that there was excellent to good. Excellent 64% of the time, good another 30% of the time. So 94% of the time it's excellent or good, which is pretty darn good. Right? And then these two measures are measures of pain as well as function. So the pain score went from anywhere from a 9 all the way down to a 1, and it lasted for greater than a year, if not longer, for all the different groups, whether the disc was in the middle, out to the side, out of the hole, all the way out of the area in the region. And the function also improved accordingly. So this isn't just us kind of like picking and choosing, but being able to determine that. So in summary, what is it that we're coming to? What we can be able to say is that there's a number of patients who have these disc herniations that are in place. And that at the end of the day, what we have been able to determine is that we can be able to not only spare the muscle, but we can be able to improve function and have less complications. So again, it looks like this, where you have less infection, less dural tears, less complications as a whole compared to traditional surgery. And it is frequently the better choice, even though Grey's Anatomy doesn't say that it is. If you found this video helpful, please hit the like button. If you'd like to learn about more different treatment options that empower you as a person or the people that you care about so you know your options, please hit the subscribe button. Thank you so much and have a great day.